Thank you very much for that nice introduction, and thank you for inviting me to this great conference. I'm attending the first time, and I'm quite thrilled to open up this whole conference. And as a moderator, even though I'm quite into the topic, as a moderator, I like to stay quiet and silent, so I leave the discussion to the panelists. And therefore, so what topic do we face today? Beyond biology, which is very important, it combines what gender health means. And the second part of the title is how gender norms shape health system and outcomes. And we just had the Slido questionnaire, and I think you answered it right, because gender and health, the biology and gender norms and expectations, they are combined in health. And gender health we discussed since decades, and I think it's a marathon and a chess game as well, at least in Germany. So we focus today on very distinct perspectives what gender health means. Sometimes it's translated to women's health, which is not. Gender health means many sexes, at least men's and women's health. So this is what we are discussing. But also queer health, which is discussed since several years, and which is quite important because people who are not binary, they have different needs and they are facing a great deal of discrimination. And I believe all over the world, even in Germany, we have quite difficulties to treat them right and to acknowledge what they need. So first of all, I'd like to welcome Professor Dr. Ute Feucht, who has come from South Africa to Berlin. Please join me on stage. Welcome. She is not only an expert, she is a director of the Research Center for Maternal, Fetal, Neonatal and Child Health Strategies at the Faculty of Health Sciences in Pretoria. So welcome. And please take your seat. So this is my seat. I'm insisting, so I'm staying here. And then I'd like to introduce Peter Baker. Welcome to the stage from UK, London. And he is a CEO of Global Action on Men's Health, which is very important, a global advocacy organization focused on men's health and gender-related health inequalities. I think it's very, very important that men start to think about their own health. We had discussed it by a cup of coffee. And last but not least, we go back to South Africa with Nate Brown. Welcome. From Johannesburg, I read. Is that right? Mm-hmm. And he is the executive director of Pan-Africa ILGA. Did I pronounce that right? ILGA. I didn't find what it stands for. Okay, thank you very much. Pan-African LGBTQIA+ Rights Federation. So welcome. Oh, we get something to drink. That's very important. Thank you very much. So it's always the little things we forget with the Congress. I know that. But I think we can manage. So we had that questionnaire, and I think it became quite clear that men really that they need to be aware that sometimes they need help. They're not Superman, not always, most of the time. So the first round, I like to open up with Ute. We decided to call ourselves by Christian names. It makes it much easier. So we would like to know, what can we improve? Santé. What can we improve to shape our healthcare system towards a gender-sensitive and a gender-equal system? So that's a topic for the first round. And in your experience, I mean, we're going to South Africa. So what challenges do face women, especially in South Africa? Or in other words, which gender norms and power structures do influence women's health outcomes the most? I think we have quite a lot. Yes, you have to push the button. I learned that.
Thank you very much. Good morning, everybody. Very nice to be here. Despite my very German name, I actually was born in Pretoria, and I went to school and studied in South Africa. And I've been working in the governmental health services in South Africa for almost all of my professional life. I come from a very patriarchal type of society. So when I was still studying to become a pediatrician, a children's doctor, I remember very distinctly that one of my professors told me, well, you can either become a pediatrician or a mother. You can't do both. And actually, so I first became a pediatrician and then I actually became a mother. And the more I was thinking around this, the more I thought she was so wrong in this assessment. It was the choice she had made in her generation, being a female doctor in a very patriarchal society. But clearly we needed to move on from that. And so in our society, we have mainly single mothers. If you look at South Africa as the general population, so child rearing is almost entirely done by women. They need to navigate all of the work-related socioeconomic realities around that. And then we have two huge issues that are also compounding this for women, and that is the HIV pandemic that we have been dealing with for the last 30 years. Which has had a very large effect on women's health in our country, and also gender-based violence, which is a huge reality for women. So that's the context I work in. So obviously I'm a pediatrician, so I work with the children, but in that because we have this very female-driven, female-centered child-rearing practices, it is mother and child is what we work on. And there are many definite issues that are at play here, which we are still working on. Yes.
Thank you very much. So you named two really big challenges, HIV and violence against women. So we come to that later, but first of all, I'd like to hear from Peter. So we started to discuss men's health more specifically since several years due to the whole gender health discussion I just mentioned. Men start to think about their health differently. And so what does global health consistently misunderstand about men's health? So, and why does that misunderstanding still persists? Are men to blame or the whole? Who's to blame?
Well, thank you very much. First of all, thank you for inviting me to talk to you this morning and be part of this panel. It is on, yeah. Also congratulations to the organisers for putting men's health onto this agenda, onto this panel. One of the interesting things that we found at Global Action on Men's Health, we did a bit of research looking at how often men's health is on the agenda in public health conferences and events, and it's actually hardly at all. It's actually very rare for men's health to get any prominence in public health discussions and at public health conferences. So it's fantastic from my point of view that you've invited me to be central to this discussion this morning. Why is men's health misunderstood? Well, I think partly there's a perception which is long. Well, first of all, I should say we've known men's health is poor for a very long time, unnecessarily poor. We have data dating back to the 17th century from London parishes which showed that male life expectancy is shorter than women's. There's no shortage of data, global data, national data on this issue. We know that in many areas men do very poorly. Why is this not addressed? Why is this not discussed more widely? Why isn't it part of global public policy debates? Well, I think partly there's an assumption that this is inevitable, that men are somehow biologically or genetically programmed to die young. We know this is not true. It's true perhaps in a marginal sense. I mean, we saw this in COVID, where male mortality was higher than female mortality, which was partly due to men's weaker immune response to the virus. But generally speaking, the contribution of biology to male poor health is actually pretty small. There's also an assumption, I think, when coming back to a fatalism about men's health, that you can't do anything about it because men will always behave badly. Men will always behave like idiots, not look after their health, put their heads in the sand, not go to the doctor. So whatever resources we throw at men, it won't actually make any difference, and it's largely a waste of money. Now, we know that's not true. We've got at least 30 years of evidence showing how we can actually develop health services that men will use, that men will actually look after their health if the services are delivered in the right way, if health promotion messaging is done in the right way. But nevertheless, that myth persists, that men are pretty useless. I think there's also an assumption, and you referred to it at the start, that gender is about women's health. It's not also about men's health. And of course, gender is about everybody's health. I think the fact that we live in a patriarchy where generally, to put it crudely, men run the world, that's undeniably the case. And I think we assume that because men are privileged and powerful in a general sense, that all men are privileged and powerful, and that's clearly also not the case. So if we take an intersectional view, if we look at how gender interrelates to race, ethnicity, social class, and so on, sexuality, we can see that there are many, many men, many groups of men who actually are pretty vulnerable and not doing very well. And we tend to forget about that when we think about men as a homogenous group. And I think the other thing, I could go on for a long time, but I think the other thing that holds us back is an assumption that if we do men's health, we're somehow damaging women's health, that we can't do more on men's health without taking resources from women's health. And of course, that's not true either. This isn't a binary choice. It's not a zero-sum game. And we have to stop this binary thinking, I think, and we have to work together. Men and women's organisations need to work together. I wish we could do it more to actually make the case for gender to be part of global and national health policy. But all these assumptions, I think, have become embedded in the way that we develop policy. We've looked at global action on men's health at 4 broad health policy areas, nationally and globally: cancer, mental health, sexual and reproductive health, and primary care. And we find across all these areas that men are largely absent. There are little pockets where there has been progress, but generally speaking, men are largely absent from global and national health policy, despite the fact that we know that men do poorly, and despite the fact that we know now how we can actually do something about this if we do the right things. And I think the final point I wanted to make is that the other reason why men's health is not being properly addressed is that men have not advocated for change. I mean, women's health organisations have been active for 50 years or more, campaigning for improvements in women's health. I mean, there's still a huge way to go. But until quite recently, men haven't actually been advocates for their own health. Men's organisations where they exist have been small, fairly weak, under-resourced, and so on. So in that sense, we are our own worst enemies. We need to actually advocate much more for the improvements in men's health that we all want to see. Well, certainly that I want to see.
Thank you very much. So one additional question. Do men take health for granted?
No, well, I think there's a myth that men don't care about their own health. I think that the way men are socialised to behave, the way we're brought up, is to actually pretend that we don't care about our own health, to take risks, to not ask for help. We saw that in one of the slides earlier. But that doesn't mean that men don't worry about their health. They don't lie awake at night worrying about a problem that they might have. It's just that we find it really hard to ask for help. So I think that men don't take their health for granted, but we actually are brought up to behave as if we do.
Thank you very much. So we dive deeper into that topic also. But first, I'd like to ask Nate, because we have a very distinctive perspective here. So in your view, so you're looking at Africa as a whole, and how do legal and social frameworks in practice influence LGBTQIA people's access to healthcare services? And regardless of the official national health policies, so what's officially written and what's actual life differs sometimes. What can you tell? Yeah, push the button. That's the trick.
Good morning, everyone. Thank you for having me here. Thank you for inviting Pan Africa ILGA to be present in this space. We are grateful to have this opportunity to share our perspective. So going back to your question, the policies say everybody's welcome, but the truth of the matter is everybody protected? You go to the hospital at your own risk. The police will tell you you are more than welcome to go there, but the community fear going to spaces because they're going to be outed or end up in prison. For example, if you look at what's happening in Uganda, you have every queer community living in fear because they don't know what tomorrow has in store. And if the policies are saying we are protected, we know if we're to go to hospital, somebody goes there and asks for PrEP. They ask you, why are you queer? Why are they being asked? What is the purpose of you asking for PrEP? Because you are going there to get PrEP to get prevention. You are going there to get your medication so that you can live longer in the space that provides for everyone. And if you're looking at it, the official forms literally says female or male. What about the transgender and gender diverse people? Where should they go? What about the intersex people? Where should they go? How do they also get support without being discriminated? So it is a lot that is happening, and you've seen that there's a lot of decriminalization that's happening in the continent as well. We need to get to a point where everybody can live freely without fearing for their lives, without being discriminated to get any form of support or any medication like any other person who is a citizen in the country. Thank you.
Thank you very much. So you were mentioning Uganda, for instance, but do you see any particular differences between the different African countries? So are there any countries which are more advanced in Africa? Can you name some, if there are some?
Yes, you have South Africa. South Africa has a beautiful constitution, right, that protects the queer community and everybody in South Africa. But there's something that I feel like, as much as we have a beautiful constitution, the health workers at hospitals do not respect queer community. I'll give you an example. There is one of our staff members who was in the country last week. They visited the hospital because they were looking for medication, in particular PrEP. They were asked, why are you gay when you're from North Africa? I feel like as Pan-Africa ILGA, we need to document these issues and reach out to these hospitals to try and do sensitization training. It shouldn't matter where you're from or what your beliefs are. You need to be afforded medication like anybody else. And then you have Botswana. Botswana as well is a beautiful country that's accommodating people. But you have other countries where I feel like they are busy with copycat laws. You see what's happening in Uganda, you're going to see it happening in Kenya. The next thing, you're going to see it happening in Senegal. So there are other countries that are coming forward and making sure that the humans are taken care of. And there are some that are going backwards and doing all the work that we've done for the past few years.
So thank you very much. Hope we have a little hope, because I want to approach to some solutions. So have the overall question: whether do solutions fail or create new tensions? So we just strived a little bit regarding the whole agenda discussion. Sometimes this provokes some protest. And Ute, so we have had strong focus on women's health, particularly the last years, the last decades, and on women's health, on mothers' health. So first of all, what is the progress we can see, the measurable progress? Do we have that?
Yes. So I think actually that's a really important question, because we often see problems and we also don't really take a step back and celebrate successes. So in our context, our large-scale antiretroviral program, the HIV program, has become a huge success. We obviously started off very tentatively, let me put it mildly. For those of you who were around 20 years ago, South Africa was was having really difficulties getting going with the antiretroviral program because of all kinds of theories about the virus and the disease and stigma, and the government that was not moving forward on actually providing the antiretrovirals. We have moved on to be we've now for many years have had the largest antiretroviral program in the world. We have about 7 million people on treatment. And I want to ask the German colleagues here, or if you had 7 million people in Germany on a long-term, lifelong treatment program, I mean, that's the scale. And I mean, you've got, 80-something million? We are 65 million people, and we have 7 million people on lifelong treatment. That's just for HIV. That's not even thinking about any other health programs. And it's not been an easy road, but we did it. We did it as South Africans, but also with a lot of support from the global community. And I mean, it's been a huge success. It did mean we had to confront a lot of realities. Initially, it was the political realities, and then there was the huge financial realities. But it was also, for us as a society, we needed to think around all those topics we didn't want to talk about, whether it's teenage pregnancies, whether it's gender-based violence, whether it is access to care for marginalized and highly mobile people. How do we actually do this? And obviously, we have not ticked every single box. There are still issues to be done, and PrEP is our new frontier because we really want to make sure that our next generation is actually free of HIV. That's what we are working towards. But it's been a success, and we can see it in the sense that, I mean, HIV for many years was a main driver of maternal and child mortality, like in very high numbers, and the maternal, so women dying in pregnancy or at childbirth, and then children dying was driven mainly by HIV for probably the last 20 years. And it has turned around because of the access to treatment that our antiretroviral treatment program is free of charge, so anybody can access that. And it's really free. So our next frontier is the Sustainable Development Goals, so SDG 3, especially for health. We're working towards universal health coverage. All of these are big topics. They're not easy, but we are on the road. We appreciate partnerships in this. And we really, our maternal and child mortality rates are still too high, and that's what we're working on for the next step. Yes, thank you.
Thank you, at least progress. So regarding HIV, so stigmatization, because before people get access or realize they need help, so they have to overcome quite some inner hurdles, I would say, so which is connected to stigmatization. So is there any program to reduce that? There was a commercial, I'm referring to a commercial in German cinemas, so where a young woman in Africa, she and a young couple, they wanted to get married, and finally they found out that she was infected with HIV, and then the catastrophe started. She was excluded from the community, the marriage was off and everything. So is there any program to get over the stigmatization?
So obviously for HIV, we started off very badly in terms of stigma. It was a highly stigmatized disease, and it was the way that's sort of a little lesson in history. It was because although obviously the virus initially came from Africa, it was actually diagnosed within the, in New York and so the US and the Europeans, and it was, and it came as a disease of marginalized communities. Whereas in our context, it wasn't that at all. We have a generalized HIV pandemic, and what often happened was that women got tested when they got pregnant, because we were doing, testing for the woman's own health, and then also to reduce the transmission risk to the babies. But that means often the woman was the first who got her diagnosis in the family, which then often meant the family sort of said she brought the disease into the home just because she was tested first. And then we had a lot of issues around stigmatization, obviously. It has become better. I don't think there's a single South African who doesn't know what HIV is. We are actually rather at the phase where we need to watch out for fatigue, where people don't think it's such an important topic anymore, which is also a phase one needs to manage, because 20 years ago we had funerals in our communities each weekend. It was really terrible to say the least, and people in the community certainly knew how bad the HIV pandemic was. Now, with 7 million people on treatment, the virus is obviously still around, but these severe effects are not visible anymore. But coming back to your stigma question, it is still there, but there's no comparison to how bad it was 20 years ago. Yeah.
Good to hear. Thank you very much, Nate. Regarding structures, so in healthcare systems, well, mostly it's not because of the lack of technical solutions, but because of underlying legal, political, or social structures still actively exclude LGBTQI people. How is that in Africa? Where do you see the systems actually failing? Is it the staff? We had that also in the questionnaire. Is it the staff? Is it the fear of people? And so, what do you see mostly?
Thank you, Dr. Martina. The fear is mostly instilled by the staff, because when the community goes to hospitals, I'll reference it to Uganda as well, because Uganda's laws are very terrible. We have our members coming forward telling us that I am unable to go and check, do a smear test as a lesbian woman, because a lot of questions will be asked. Why are you dressed like a man if you're having to come here to get a smear test done? That already is very problematic, because if somebody walks in, they are expecting to get a service. You don't have to ask a lot of questions. The person says, I need a smear test. You need to provide them with a smear test. You have people going in there wanting to do an HIV test. They get asked a lot of questions. So people are not going to come in. People that are on medication, they get asked too many questions, they don't come in. So you have higher numbers of people dying. They decide to stay at home as the queer community and feeling like they are not safe in the spaces. Sensitization trainings have been done for so many years, but there's no improvement. I feel like as much as there are laws, the laws are basically creating barriers. The laws are not protecting the community, because how are we in 2026, we are still having people fearing to go to hospitals to get adequate health care?
That's not good to hear, because then if they are afraid to get the tests, so it's a danger to whole society as well. So we'll see what we can do about that, Peter. If we involve men more closely in gender equality and in the health system more consciously, where do you see specific tensions in terms of priorities, resources, and also political acceptance? And how should these tensions be addressed? So I'm asking that from the background that in Germany right now we have a female healthcare minister, and we get a lot of support. We are delighted because of that support from policies for women's health and funding for research. But however, voices raised claiming that men are being discriminated, disadvantaged, and even though, we had that with our coffee break, even though the male body is still used usually are the benchmark for classifying and assessing many symptoms or laboratory results. So where do you see, what can we do actually to involve men equally in gender equality in the healthcare system, so that we have a focus? This is a man, he needs more, he needs specifically this, and a woman needs different things.
Okay, I think we need to change our perception of what doing...
Did you push the button? Oh, very good.
I think we need to actually change our perception of what doing men's health means. And I think we have to actually understand that men's health is a public health issue, or poor men's health is a public health issue. It's not only an issue for men. Obviously, where men do badly, that's not good for them. But poor men's health is a wider issue. It's a problem for their partners, it's a problem for their families, it's a problem for the communities they live in, it's a problem in their workplaces, and it's a problem for society generally, because poor male men's health is expensive. When you've got men lying down because they're ill, it's more expensive to look after them than if they're standing upright and walking around doing useful things. So we need to take a broader view of what men's health means, and if we improve men's health, we improve public health generally. I mean, there was a slide earlier in the exercise about the burden of caring. And of course that falls mostly on women, both partners and daughters. So when a man is ill, the family suffers often in many countries because the man is the main breadwinner. His partner or his children have to take time off work or stay out of education to look after them, and that's not good for them in obvious ways. So poor men's health has a ripple effect throughout society. So if we improve men's health, we improve everybody's health. Where action has been taken to improve men's health, I don't think it's caused the kind of tensions or difficulties that is often imagined. I mentioned earlier that men's health hasn't really been incorporated into public policy around the world, but there are a few chinks of light. So there are 9 countries at the moment, there will be 10 soon, but 9 at the moment that have national men's health policies. My own country, England, introduced one last year. There are well-established policies. There was one in South Africa. It's just come to an end, but there is a men's health policy in South Africa. There has been. There's also the countries that have most sustained activity around policy development in men's health are Australia, Brazil, and Ireland. And there hasn't been a backlash against the introduction of those policies that I'm aware of. Generally, they've been well received, and they've been to different extents effective. So I think there's been, when action is taken to improve men's health, I think it's broadly welcome. But we have to make sure, of course, that as I said in the answer to the first question you asked me, that when action is taken to improve men's health, that's not at the expense of women's health or any other group, that we need to actually make the case for more investment in the health of everybody, not just for men, obviously, but for women too, and children and adolescents and so on. I think also, if we take action to improve men's health, one of the key issues in men's health is access to primary care. We know that men are diagnosed late very often because they're not presenting to general practice or pharmacy or other primary care services. And we need to improve men's use of those services. But if we do that, if we make those services easy to access, we actually make it easier for everybody. So the benefits are not just for men, they're for women too, and the whole of society. So action for men's health is not it doesn't have a kind of niche benefit. It's actually good for the development of those services as a whole.
Thank you very much. When I'm discussing men's health, so one issue is also that the hurdles to just what you mentioned to get access to the healthcare system are too high for men, especially when they're the breadwinner. And with our Congress, we had a doctor with us who is a doctor with VW. So with big companies, they have their internal doctors, and then on the workplace, they get the access to men and to address them. I don't know if it's an approach for every country, but how is it in England?
Well, I think the picture is quite mixed, but generally speaking, we think that employers could do a lot more to improve the health of their workforce. And in male-dominated industries like the car industry and transport, mining and other industries, construction, farming, there are huge opportunities to actually improve the health of men. But I think the challenge is not just to do that. I mean, we've also seen initiatives based around sport. We know that not all men are interested in sport, that's a generalization, but many men are. And we have seen very effective health initiatives delivered at football grounds, for example, or in my country, cricket. Some other countries play cricket, not many, but South Africa's good at cricket, yeah. If we go to where men are, that can actually make a difference and is a very important part of how we can improve men's access to services. But the challenge is really to how we improve mainstream health services. That's what we really need to do, and that's, I think, partly a challenge for general practice, but we also think, and we're doing some work on this at Global Action at the moment, is to think about how we can improve the use of community pharmacy as an access point for men. Because we know that men don't use pharmacies very effectively. They don't ask pharmacists for advice. They just assume that pharmacists are there to hand out pills and are not a potential source of health information and guidance. So we think there's a lot more that can be done in that area.
Thank you very much. We have a similar discussion also in Germany to involve pharmacies much more into the healthcare system. So before we continue, I'd like to open up to the audience, because I think you have some questions too. And do I see any? So we have microphones on the right side and over here. Please, would you be so kind to tell us your name and where you come from? So the microphone is coming to you.
Hello, I'm Arash Rashidian from WHO. I'm coming from the regional office in Cairo. So many thanks for the rich discussion, a lot of useful information and perspective. So I'm going to ask a provocative question to anyone who wish to take it. There was a lot of discussion about how to improve access, change attitude and perspective, the outcomes, etc. What is your key message about shaping health systems for gender norms? So, I mean, one idea could be, for example, we could have departments for men's health in the ministries of health or things like that, which has the danger of verticalizing program, not changing. If not that, then what? I mean, the reason I'm asking this question is that, so for women's health, focusing on certain diseases or problems or life cycles, for example, maternal health, helped the attention. What are the areas for male gender, transgender, that can help to change the discourse at the global level and national levels?
So thank you very much. It's a very question for solution. So anyone has a solution? So it's what you wish for. You can really can address the wish fairy. Yeah.
Yeah, let me start. So that is it is just such an important question, and one of the major points in our setting that we are working on is how to actually get away from vertical programs. And I mean, our HIV/TB program has been a very prime example. Now, the problem that you face if you are, if a major epidemic like that or pandemic comes along, is you are in emergency mode, and you really you have a very strong vertical program, but you have to go and integrate that into what's happening, especially at primary healthcare level. So in our context, we have moved towards very much like a focus on the first 1,000 days, for instance, for their mothers and babies. So for antenatal care, we've moved from 4 to 8 routine antenatal visits where everything happens. The idea is that the mother, except if she has a complication, she will only see the one service point for her pregnancy visits. And that has been very successful. We are now moving over to doing the same postnatal. So first 1,000 days would be up to 2 years. That's our current focus. So as soon as the baby is born, it was always very much a child-focused intervention now. And we are now moving towards integrated postnatal care, where when the mother brings her baby for the immunization visits, for instance, that we also provide all the services she needs, which would be contraception, it would be HIV prevention, it would be HIV treatment, it would be mental health, all of that. It's not easy to do, but we're very intentional about that at the moment, and we are going to roll this out in our country now. That's our next step, the sort of the postnatal phase. But it's all about integration.
Thank you very much, Peter. You have a solution as well.
Yeah, I think it's a really good question, and it's a pretty challenging one from a men's health perspective, because the inclusion of men's health in policy and in service development is so fragile that we need to think very carefully about how we can drive it. And I think for me, one of the most encouraging developments has been what I referred to earlier, the development of national men's health policies. In fact, the WHO in Europe has taken a step in this direction, because in 2018, WHO Europe region published its own men's health strategy for all 53 member states. The implementation of that hasn't been great, to say the least, but nevertheless, the intention was excellent. And I think that a policy like that has to be driven politically. And I think that's why it's so important that I don't know whether we want to go down the road of ministers for men. I think that's something we could discuss, the merits and demerits of that. But we certainly need to make sure that somebody in government, a minister in the health department, has responsibility for men's health, as well as somebody perhaps having responsibility for women's health. I think it needs that political. The governance has to be such that it's driven by political will. But I think beyond that, I think what needs to happen is not just free-floating independent men's health policies, but the integration of sex and gender into every health policy. So I think all policies need to be proofed, they need to be checked, they need to be assessed to make sure that they actually take full account of sex and gender affecting everybody, not just men, but men and women, not non-binary and so on. So I think that's something that we need to make sure is integrated fully into policy making.
Thank you very much. So we have quite a lot of questions. Please ask shortly, because we're short of time. So we have a gentleman in the third row, after that here and here. I'm back there. So first of all, you already have the microphone. Yes. It's yours.
Yeah, thank you so much. Pedro Villarreal, Institut of Wissenschaften und Politik. So my question is for Nate Brown, if I may. So you mentioned the role of laws, right, in protecting, or rather not protecting communities, vulnerable communities, especially when it comes to the relationship between staff and patients, for example. So do you have any proposals or ideas on how concretely, right, could laws play a better role in improving that relationship and making vulnerable communities more protected when it comes to their health needs, right?
Thank you very much for your question. I think from my perspective, I think what needs to happen is to get to a point that health workers are trained, because they become gatekeepers. I think there has to be a law that health workers should not discriminate, regardless of who you are, because I don't think at the moment the laws really have those clauses. We have a law that's just general, that come as you are. But if I come as I am, I do not get the protection that I need. And also, with these health workers being trained, these hospitals are underfunded. They will not go out of their way to make sure that sensitization is done because of the funding cuts. So if the government may or possible fund certain trainings, I think there'll be a huge improvement, and make sure that policies include protection for the patients that come to hospital, especially the queer community.
Thank you. Please. You have to push the button.
on this question on how much education and training for health professionals is key and to really change things on the ground rather than not necessarily only the laws and regulations and policies. Would you say, over your experience of this 20, 30 years that you have seen, that this is improving in a way that health professionals are really keeping the necessary the sensitivity, but also knowledge about how gender norms are shaping health and their behavior, in their own behavior towards patients? Thank you.
I think it's a question for all of you. Who wants first?
I'll jump in first. From my perspective, I think there's still a big gap there. I think that while clinicians, for example, are well trained in terms of dealing with issues like prostate cancer or erectile dysfunction and other sort of male-specific conditions, when it comes to understanding gender-responsive healthcare in general, I think there's a huge gap. And I think that we need to do a lot more to embed that into pre-qualification training for health professionals of all kinds. But we also need to make sure that there's post-qualification training as well. And there's pockets of that. There's training programs for pharmacists, for example, in men's health in the UK, other bits and pieces for general practice, but not very much. And I think it needs to become part of the mainstream medical and health and professional education.
Still, we have a long journey ahead of us from the first idea up to the real life. It's a long journey. So here, and then I've seen you.
Thank you so much. My name is Natalie. I'm working as a youth advisor to the Ministry of Health of Ukraine. And my question would be to Peter. Coming from Ukraine, what we realized is that how you can support men's health is the peer-to-peer approach when a man comes to another man saying, hey, I've been to that before, and I know how to help you. And my question would be, from your perspective, what are successful examples when you used advocacy plus the right choice of stakeholders, when the initiatives and advocacy programs actually worked out regarding the men's health? Thank you.
So you're asking me what examples are there of effective men's health advocacy?
Yeah, the successful examples of advocacy for men's health.
Okay. It's a good question. I mean, I think we have made progress. For example, as I mentioned before, in my country, England, we have recently introduced a men's health policy, a national men's health policy. It's not for the whole of the UK, it's just for one part of it, but nevertheless it is real progress. And that didn't come about by chance. That happened because it was consistently advocated by civil society organisations over a long period of time. In fact, going back 25 years. So it took a long time to get there. The same was true in Ireland, where, again, the men's health policy, which is was the first men's health policy in the world, happened because civil society organisations and medical groups worked together to campaign for that. One issue that we're very active on at the moment is around HPV vaccination, trying to get HPV vaccination programs globally extended to boys. That's happened in Europe. It was incorporated into the Beating Cancer Plan, which the European Commission published in 2021. And that didn't happen by accident. That came as a result of consistent advocacy by cancer organisations and others in Europe. So men's health, the introduction of change in men's health doesn't normally happen by accident or because somebody sitting in a Ministry of Health thinks it's a good idea. It happens because of advocacy. We now have a men's health policy being developed in Canada. Again, that was a result of advocacy by men's health organisations, and Movember played a particular role there and actually helped to, I think, change the way that men's health was discussed and debated in Canada. So we do need advocacy to make these changes. It's not going to happen by accident.
Nothing's going to happen by accident. So we have one question over there, and it's the last question. I'm sorry, I have to close up because I see the Parlamentarischen Staatssekretär, Dr. Kippels, already sitting in the first row, and I leave the further questions to the coffee break where we can discuss it further. So please.
Hello, my name is Veronica Thiel. I'm a freelance researcher in health and digitalization, and I was wondering if the panelists have accounted or ideas of projects where data-driven evidence has helped shape a policy, and if that would be an opportunity to further drive the agenda. For example, NHS England has fantastic data, probably the best data set in the world in the health system, that allows to pinpoint for public health analysts to say, the number of men being diagnosed late in A&E with cancer is much higher than for women, to have that sort of comparative approach to drive politics towards being active. Thank you.
Okay, Ute.
Yeah, so I think that's an excellent question, and obviously data should be driving what we are doing. What doesn't get measured doesn't get done is certainly true within the healthcare sector. So one example from our setting is we have been having a mortality audit system for the last 25 years for all maternal and newborn and child healthcare mortalities in South Africa. So every single death of a pregnant mother or of a neonate or of a child gets actually formally audited. There's a whole process around that. It's and the whole idea is not punitive. It is all about quality assurance. So the case gets discussed within a clinical context, and then that data is then also collated nationally. So we have a very good idea what the causes of death are for mothers and children in our context. And we have been using that for 20, 25 years. That's why we know how severe the impact of the HIV epidemic was. That's why we know how severe COVID actually was for us, for mothers and newborns. Our maternal and newborn mortality actually went up very severely during COVID. It took us back. We were very happy to see the SDG targets on the horizon until COVID came, and it really up, but now we are back on a downward trend and we know where we are going. This is driven by clinicians on the ground, but it's also a national program. We have ministerial committees that are embedded in our National Department of Health, where actually this data is being collated and the reports are written, etc. And it certainly drives policy in our setup. But it doesn't happen by accident, just as you say. It's hard work, and you need to be very intentional about this. But clearly, that's what we need to do. Yes.
Thank you. Peter.
I wish data did drive policy. If it did, then, you know, in my field, there'd been action taken on men's health long before now, because we've known, as I said before, how bad men's health outcomes are. We've known that for a very, very long time. It's politics. It's basically about creating the kind of political, the coalitions that drive change to actually build advocacy. I mean, I mentioned HPV a moment ago. I was involved in a campaign in the United Kingdom to persuade the government to introduce a gender-neutral vaccination to get boys onto the programme. It took 5 years to do that. 50 organisations worked together to campaign to make that happen. We actually threatened the government with legal action under sex discrimination law if they didn't make the change to extend the programme to boys. And it was actually that tipped the balance. It was about politics, getting politicians on board. It was certainly about the evidence. We had to have the science to actually justify what we were doing, but on its own it wasn't enough. We had to use the law, we had to use politics. That's what drives change.
Politics is the key word, but before we come to the politics and politicians, I like to close up. Please keep your questions, ask them during the coffee break and the lunch break. And one last question, one sentence for each. So what can we do? We just learned that international support is crucial to make changes, even though we need a long time. So what can each one of us do to improve the gender health gaps, to improve the systems, to improve? Nate, what's your proposition to us?
Thank you so much. International actors need to begin with humility and political intelligence. First fund community-led infrastructure, not a short-term project. drop-in centers, one-stop shop clinics, peer outreach, legal support, and community-led monitoring are not side activities. They are the access architecture for communities that public systems often fail to reach. In Uganda, 84 PEPFAR-supported drop-in centers helped sustain access during the crisis by adapting through telehealth, multi-month dispensing, decentralized pickup, and peer support. Lastly, protect people quietly and practical. That means flexible emergency funds, legal aid, secure operations, digital safety, psychosocial support where necessary. Relocation support, protection should not be performative. It should keep people alive and organization functioning. Thank you.
Thank you. Though it's quite a list, so we have a lot ahead of us. Peter.
I'll be very brief, and it's simply, my message would simply be don't believe the myth that men aren't interested in their health. They may not say they are, but they really are.
Okay, that's good to hear, and I will tell my husband, Ute.
So mine would be strong win-win partnerships will take us a long way forward. And yes, so thank you for the great discussion.
Thank you for the great discussion, for your expertise, and thank you for listening, for thinking, and for asking all your questions. So I hand over to politics. Thank you very much.